I apologise. My name is Goretti Horgan. I want to welcome you to this public meeting for the campaign for National Health and All Ireland National Health Service. I'm speaking to you from Derry in the north, where we do have a National Health Service, but one which is being constantly eroded by privatisation. Not as bad, I'm glad to say, as in England, but still we're constantly having to battle to keep our health service free at the point of use and ensuring some level of equal access here. I'm not going to say anything much more at the moment about health inequalities here in the north, although I will later on, because we're going to go straight to Harvard to Dr. Adam Gaffney. And Adam is going to talk about, the health inequalities in America, which really are largely the result of the dreadful healthcare system that they have there. I'll let Adam introduce himself, I think, and tell us his background, and then hopefully we'll have him for maybe 10 minutes or so. Thanks, Adam.
Well, great. Thank you for that introduction, and thanks for having me on this meeting. So yes, my name is Adam Gaffney. I'm a pulmonary and critical care physician here in the Boston area in the States. I'm also an instructor in medicine at Harvard Medical School. My research focuses on, I think, some of the issues we'll be discussing this hour: health inequalities, health disparities in terms of access and outcomes in the United States, with a focus on people with lung disease, who are often my patients. And then with another hat, I am currently president of Physicians for a National Health Program, or PNHP. This is an organization that was formed in the late 1980s in an effort to resurrect the fight for what we call single-payer healthcare. It goes by a lot of names, and it's now referred to in the U.S. context as Medicare for All, which you may have heard of, particularly in the context of the recent presidential primary elections. So I thought for these 10 minutes or so, I'd talk a little bit about where this Medicare for All campaign has come from in the U.S., where it has gone in the last few years, how things stand in terms of health inequalities in the United States at the moment, including through the lens of the COVID-19 pandemic, which in so many countries has laid bare so many of the injustices and dysfunctions of not only our healthcare systems, but in many cases of our societies more broadly. And then a quick look into the future, perhaps. So like in many other places, the push for true universal healthcare in the United States is not a new one. Really, it goes back at least a century, back to the New Deal era, probably is when the first national campaign began. Progressives, people on the left, were hoping that FDR, Franklin Roosevelt, would push for or include national health insurance in the New Deal. This is the 1930s, and this is a moment when universal health care is, of course, on the agenda in many countries. New Zealand implements its or passes its legislation in 1938. Roosevelt walks away from this, and in the post-World War II years, like many places, there is a renewed effort to pass national health program, similar to that in many European countries. So in the 1940s, this gets underway, and it's actually in the United States, the physicians and a group called the American Medical Association, which has traditionally been highly conservative in its political orientation. It's the American Medical Association that defeats the push for national health insurance in the late 1940s in the United States. It's sort of tarred as being, a communist plot. This is a Soviet invasion of a medical flavor. I'm barely exaggerating in terms of the kinds of rhetoric and red baiting. And this is a moment of Senator McCarthy, a really sort of regressive moment in American history when people on the left are sort of pushed out of the public sphere or out of their jobs altogether. And so this is the defeat. And at the same time, of course, in other places, in other parts of the world, there is successes. In 1946, of course, the United Kingdom passed legislation leading to the National Health Service. So right at the same time. And these movements, whether you look in the United States or you look abroad, have many common underpinnings. They're favored and supported by labor and often labor parties where they exist, which was not the case in the United States, and other progressive elements, political elements in society. They're the result of major social movements. And when successful, at their best, these movements have created political, social, economic rights to healthcare. Even in places when the when the sort of rhetoric of human rights, the rhetoric of economic rights is really not at the fore of these struggles. In the 1940s, it was not, even though this is precisely the moment when, human rights rhetoric sort of becomes a thing. It's embodied in the founding documents of the United Nations. The Universal Declaration of Human Rights includes, for instance, a right to medical care. But these first successful efforts at achieving these sorts of programs by and large, do not use the rhetoric of rights. But it doesn't really matter because the idea is the same. In the United States, in the subsequent decades, there have been multiple subsequent efforts to achieve universal health care. In the moment of the civil rights era in the 1960s, when rights for Black Americans are being fought for and won in many cases, something called Medicare is passed. Medicare is a public health insurance program only for the elderly, however, ages 65 and older, and it includes things that we call co-pays, deductibles, out-of-pocket payments. So even though it's public, it is not free at point of use, which is one of our demands, and I'm sure it's a shared demand. And in the 70s, there's another effort, of sort of real progressive push, labor, other elements to achieve national health insurance. But it all goes down and nothing is achieved until really 2010, when President Barack Obama passes the Affordable Care Act. And many Obamacare, and the Affordable Care Act was, sometimes viewed as being, well, the right wing has sort of cast the Affordable Care Act as being socialized medicine, which it is not, unfortunately, I would say. It's also been described as a universal system. But alas, it is not that. And that is why we are in the position we are today. The Affordable Care Act expanded a public health insurance program for people with low incomes called Medicaid. And it also further subsidized private insurance for lower income individuals and regulated it to take away some of the sort of worst aspects of the pernicious private insurance plans, which, in the United States, you could basically be denied if you had a medical condition, or you could be charged more because you had a medical condition. In fact, you could be charged so much that it was simply impossible to get insurance, even assuming you had the money and wanted to spend it. So the Affordable Care Act sort of pushed, made significant changes that did help many people gain some sort of coverage, mostly through that Medicaid expansion, that expansion of a public program for low-income people that I mentioned. But where has this left us? Well, despite those gains, Medicare in 1965, the Affordable Care Act in 2010, and I hope this isn't too much in the weeds in terms of American healthcare history, but I also want to leave listeners with some information and not just my opinions. Despite those passages of those legislation, we have a very unjust, very fragmented, very inequitable healthcare system. Currently in the United States, about 30 million people have no form of health coverage whatsoever, which means that they either avoid going to the doctor or avoid going to the hospital, or if they do, when they do wind up at the hospital with, say, a heart attack or a gunshot wound, they may accrue bills in the thousands, tens of thousands, hundreds of thousands, even in some cases, millions of dollars. And so this can, of course, is unaffordable, and many Americans go bankrupt because of the healthcare costs. In fact, one study by colleagues of mine found that perhaps a majority of bankruptcies in the United States are associated with medical problems or sickness in some form. So that's the lay of the land right now. 30 million people uninsured. The United States also has another problem that's totally separate from the problem of uninsurance. And it speaks to the importance of moving towards a true single payer type system and not merely a fragmented patchwork quilt of different programs that cover different people differently. Because that's where I think some people think we should go. And the problem with that is as follows. So in the United States, even for those who have some form of coverage, that coverage is often inadequate, meaning there are high copays and deductibles. Copays, I think you'd refer to as user fees. But we also have deductibles, which are amount out of pocket you have to pay before the insurance kicks in at all. So for some plans, like a family plan that you buy on these Affordable Care Act marketplaces online, the family plan, the most commonly purchased one, has a deductible of $8,000. That's not the money to get the plan. That's the money to use it before it kicks in. And we know from lots of data that has been generated that, not surprisingly, and perhaps you don't even need these studies, that causes people to go without needed care, to avoid showing up at the emergency room in the throes of a heart attack after developing chest pain. Women with breast cancer delay diagnosis and treatment of their care because of those high copays and deductibles. And I could go on for various conditions. Some of my work has looked at these deductibles effects on patients with chronic obstructive pulmonary disease. So that's where we are right now. And roughly 44 million Americans, at least, in fact, the number's higher, are underinsured. Now, even if you put aside the underinsured, everyone else faces all sorts of other issues. First of all, the coverage, even if you have low deductible or no deductible, you still have out-of-pocket payments. Almost everyone has out-of-pocket payments when using care. You can only use care with certain providers. So, for instance, you may be covered at one hospital, but not at another. And if you go to the wrong hospital, you may still get billed, even though you have, quote unquote, good insurance coverage through, say, your employer. Furthermore, even the public plan, the Medicaid plan that I mentioned, which is a good thing in that otherwise those people would have nothing. Even that plan in many states in particular, less so in my state, relegates those individuals to a lower sort of level of access. They can't necessarily go to the same specialists or the same cancer hospital. So it fundamentally creates a class-tiered healthcare system where people's access to care is dependent upon their economic means, not on their health needs. And, that clashes very directly and very fundamentally with the notion of a right to healthcare, which means going beyond a class-tiered healthcare and going towards human-tiered and universally tiered. So finally, I think I'm just about at the 15-minute mark. I'll just close out my last, 2 minutes with giving a sense of where things have come in the United States recently. Because although I've painted a very dark picture, perhaps, and that's things are only getting worse, I should say, in the Trump era. We have had probably 2.3 million more people uninsured since Trump took office. Over 500,000 more children uninsured since Trump came into office. Putting that aside, and I should say millions more are going to lose coverage because of the unemployment surge from the COVID-19 pandemic. So even putting that aside, I do want to mention some of the strides forward we've made in the Medicare for All movement. When I first got involved, I've believed in this cause passionately for I think my whole adult life. I think it's fair to say. Although I was committed, it seemed extremely far off as a goal. It seemed like it was a fairly radical idea that was not in the mainstream. And boy, have things changed. From Bernie Sanders' 2016 presidential campaign, where he got behind Medicare for All. In fact, he made it the center point of his campaign. Medicare for All became something that now most Americans are familiar with, at the very least. And in fact, many opinion polls show majority support among Americans. That from then, we had a bill in the House of Representatives, which is our lower house of Congress, that actually had a majority support among the Democrats in the House. Sanders launched a Senate bill that earned about a third of Democratic co-sponsors, which might sound like not a lot, and it's certainly not enough. But keep in mind that Sanders' previous bills that he's sort of put out there, he was the only sponsor in the Senate, right? So we now have bills in the House and the Senate that have acquired support from not just sort of the radical lawmakers, but from more centrist Democrats. Not all of them. So not a single Republican. That was in 2016, and obviously the 2020 campaign pushed things forward even further with Sanders, again, getting behind Medicare for All. And, in the medical community, we've made strides as well. I mentioned at the top of the hour that the American Medical Association, defeated the predecessor to Medicare for All in the 40s. Well, last year, our activists really pushed the AMA, and at the very least, they've pulled out of a lobbying group that's trying to defeat Medicare for All. They don't support it, but that's another issue. Another medical specialty group, the American College of Physicians, this year endorsed Medicare for All. Another group followed. So I can't really give a full discussion of sort of everything that's happened in the last 5 years, but suffice it to say, popular support is actually quite high. We've made inroads in Congress. Within the medical community, we've certainly advanced the cause and have support from some medical societies, which we think is extremely important given the history of healthcare reform in many countries. But of course, needless to say, there is an enormous amount of work ahead. There are enormous barriers to success ahead. And that says nothing about where we're going politically as a country, which is going to leave a lot of questions unanswered. So thank you, and apologies if I went over a few minutes.
No, don't apologize, Adam. That was fascinating. Thank you very much. It's really, really interesting. And it's just amazing how much information you managed to get into that 15 or so minutes. I'm going to hand over to Colette in a moment. I just want to say, though, I don't know whether it's been seen in America, but there's been a mini series here on TV called Mrs. America about the ERA, about the attempt to pass the ERA. No, you didn't see it? Okay. Well, anyway, Gloria Steinem wrote an article which informed us all that actually what defeated the ERA was not general misogyny, but rather the insurance companies, because until Obamacare, until the Affordable Care Act, they could charge more they could charge women more, because babies. I just thought that was amazing, that they could do that they could actually charge extra for just because you have babies. Anyway, so I'm going to hand over to Colette now. Colette Bennett works with Social Justice Ireland and in policy work, so she can tell you more about herself now. Thanks, Colette.
Thanks very much, Goretti. So thank you, and thanks for having me. So as Goretti said, I am a research and policy analyst with Social Justice Ireland, and that's an independent think tank and justice advocacy organisation. So what we do is we seek to build a just society, and you can check out our work on socialjustice.ie. Now, what I'm here to talk to you about, and again, thank you, is health inequalities generally in Ireland. And the first thing I'd say is that health isn't just about healthcare. So the link between poverty and ill health is really well established, both in national and international research. In fact, the World Health Organization commissioned back in 2008 on the social determinants of health found health is influenced by factors like poverty, food security, like social exclusion, discrimination, poor housing, unhealthy early childhood conditions, poor educational status, and low occupational status. So there's a huge array of things that influence health, that have an influence on health, and that obviously then there's an effect. In my report, the OECD again underlines that large inequalities in life expectancy exist by social status. So again, including educational level, income or occupational group. And on average across OECD countries, people without a high school diploma expect to live about 6 years less than those with a third level education. People on low incomes are less likely to see a doctor because access to preventative services is concentrated among the better off. And obviously there's that inability to be. Those findings then echo the findings of our own recent report on our European research series. And that found that while the quality of healthcare is high enough in most EU countries, there are still significant variations between countries with regard to both quality and access to healthcare. So perceptions of unmet need, for example, for healthcare, and perceptions of poorer quality healthcare continue to be greater amongst poorer people in Europe than those in richer areas. In Ireland, studies from the Irish Public Health Alliance detail striking differences in life expectancy and premature death between people in different economic groups. And another OECD report from last year suggests differences in how Irish people report being in good health depending on their income group. So only 7% of people in the lowest income quintile, that's the lowest 20%, assess their health as good, compared to 93% in the quintile, that higher 20%. A range of studies then provide evidence that's of great concern to us and obviously relative to inequality and health in Ireland. So the 2018 Healthy Ireland survey, for example, highlights how those in more deprived areas are less likely to rate their health as good or very good, are more likely to have long-term health problems, and are more likely to smoke and binge drink. The 2019 version of that report that people living in deprived areas are more likely to report that they'd suffered from a wide range of 25 conditions that they were asked about within the past 12 months compared to those in wealthier areas. So in terms of the age differentials, that first OECD report that I mentioned earlier on, that found that Ireland was one of 5 OECD countries where people aged 65 and over in the lowest 20% of the income bracket are more than twice as likely to report living in poor or fair health compared with adults in the top 20% of the income bracket. At the other end of the lifespan then, the Growing Up in Ireland study, which is a longitudinal study of children and infants, they highlighted a widening health and social gap by the time children are just 5 years of age. So children from the highest social class, those whose parents are in the professional or managerial sectors, they're more likely than those from the lowest socioeconomic groups to be considered very healthy and to have no problems. Another study from that series, that Growing Up in Ireland series, shows that economic vulnerability, particularly persistent economic vulnerability, has negative consequences for the socio-emotional development of children. So that reinforces the need for a policy focus on child poverty and deprivation to also address child health. Obviously, children's well-being is still very much shaped by their parents' circumstances and their parents' social position, which results in persistent inequalities then, despite improvements that might be made in health or education and other areas in Ireland over time. Looking then specifically at life expectancy, again, it's another area where differences between socio-economic groups exist. So overall, Ireland shows an increasing life expectancy since the 1990s. Life expectancy in 2017 at birth stood at 84 years for women and 80.4 years for men, both of which were above the EU average. However, life expectancy then differs based on your socioeconomic group and your background. For example, life expectancy at birth of males living in the most deprived areas in the state was just 79.4 years, compared with 84.4 years for those living in the most affluent areas. So you're looking at a 5-year difference there. The corresponding figures for females then were 83.2 years and 87.7 years respectively. So that differential between female and male life expectancy was greatest in the most deprived areas. And that shows how poverty directly affects life expectancy and the incidence of ill health. It also limits access to affordable healthcare. It reduces the opportunity for those living in poverty to adopt a healthy lifestyle. Basically, poor people get sick more often and they die younger than wealthier people, and something that's been acknowledged by our own Department of Health in policy papers. One of the most obvious concerns then about the Irish healthcare system is access. And I mean, I know that's a key concern of yourselves. Ireland's health system ranked 22nd out of 35 countries in the 2019 Health Consumer Powerhouse report. But in the issue of accessibility, we actually ranked the worst. Now, that report notes that even if waiting list targets of 18 months were reached, it would still be the worst waiting time situation in Europe. We know that Irish hospitals are working near full capacity, and we're in and around the 95%. And the occupancy rate for acute care, as in hospital beds, is among the highest in the OECD countries. It's actually 20 percentage points higher than the OECD average. So while that can be a sign of hospital efficiency, it can also mean that too many patients are being treated in hospitals when they would more appropriately be treated at home or within a community setting if those services were available to them. Also, by comparison with other OECD countries, the share of the Irish population delaying or going without care is also comparatively high at about 30%. Our two-tier healthcare system for access to public hospital care means that private patients can access hospital care faster, and that's in terms of both diagnostics and treatment, while those in the public system can spend lengthy periods waiting for a first appointment with a specialist or waiting for treatment. The latest statistics from the National Treatment Purchase Fund from July of this year show that there are now more than 600,000 people waiting for outpatient appointments, and more than 1 in 5 of those is waiting 18 months or more. Problems with the Irish healthcare system are obviously often evident through access. However, it goes beyond all of that. Sorry, now I've lost my place on my side. We know there are barriers in access to primary care. We know there are delays in accident and emergency departments. We know there is, increased waiting times, as I've just said, in relation to those 600,000 people. And international experts have noted that Ireland is the only EU health system that doesn't offer universal coverage of primary care, and that despite increased investment during the previous decade, when the financial crisis of 2008 hit, Ireland still had poorly developed primary and community care services, and we still do. Accessing our system depends on whether you have a medical card, a GP visit card, private health insurance, private resources, your own money to spend on health services, where you live to be able to access health services and whether or not they're available, and what type of services you're actually trying to access. So it's also those who are poorest, sickest, and those with disabilities who find it hardest to pay those charges, to negotiate those access, and who ultimately end up waiting longer for their care. Those who are poor and sick without medical cards fare worst in terms of coverage and access. So in 2017, almost 1 in 3 households where at least one person had a medical examination or treatment in the previous 12 months reported that costs were a financial burden. For households with children, the corresponding rate was higher again. It was over 35%. Now, we can't talk health without talking COVID-19, and I know the previous speaker touched on it. We know that many of our frontline workers, our healthcare workers, our shelf stackers, our postmen, our bin men, much of the so-called unskilled labour is low paid. These people who are at high risk of contracting COVID-19 every day. For those living in what's called intergenerational households, so where granny and granddad and mommy and daddy and the kids are all living under the same roof, they're bringing that risk home to people who, by virtue of their health, their age, their frailty, or any other vulnerability, are at, again, an increased risk. In terms of the numbers, there's a new COVID GeoHive site, and it's very interesting, or very interesting to people like me anyway. And I had a look at some of the Dublin numbers just for today's event. And really what it shows is it's incredibly interesting. It's quite stark, actually. What it shows is an incident of COVID-19 per 100,000 people per local electoral area. So it's kind of small enough site maps. And some of you might have seen the article in the Irish Times by Deirdre Falvey. She compared Blackrock and Mulhuddard. So just to expand this out a little bit, to give a bit of data around it, the national incidence rate for COVID-19 as of the 2 weeks prior to the 21st of September was 70.7. This compares to the rate in areas like Blackrock. So Blackrock has 47.7 as a rate. The rate in Dundrum was 48.1. In Dunleary was 60.1. In Fairhouse, Bohernabrina was 70.2. If we pop across the imaginary boundary that separates the electoral area of Fairhouse and Tallaght South, we see that Tallaght South has an incident rate of 166.4, so more than double that of Fairhouse, Bohernabrina. that shouldn't exist. Clondalkin has a rate of 150.5, Blanchardstown has a rate of 127.5, and Ballymunfinglas, which is where I'm originally from, has an incident rate of 265.4. These numbers, as I said, are stark. They're startling. And if anyone on this webinar, believed it before, they completely debunked the myth that COVID-19 is a great leveler. Clearly, they point to inefficiencies and inequalities in health. So what can we do about it? Well, Budget 2021 is just around the corner. It's due to be announced on the 13th of October, and it provides an opportunity for government to finally grasp the nettle of dealing with healthcare inequalities and addressing the two-tier system and investing in primary care and community healthcare networks. We really need to look at allowing people to age well at home, to reduce and eliminate the numbers of delayed discharges, to increase the number of home care packages that are available to people, and to create the environment within communities that's proven to have a positive impact on all of the issues that I just spoke about earlier on. It would also free up spaces in acute hospitals for those who need acute care, and it can reduce our capacity rate to below that 95%, which it currently stands. Government needs to properly fund Sláintecare, and that includes the 500 million per year for 6 years on infrastructure. That was committed to in the Sláintecare plan back in 2016, that got cross-governmental support and has not been properly implemented. We need more GPs, we need more community healthcare teams, and we need a reduction to the prescription charges from €2 to €1.50. Last year's budget did it for those of 70 and above. We need that across the board, given how systemic healthcare inequalities actually are. We also need to properly address the waiting lists for people with mental health supports and those with dual diagnoses. A report from the CSO showed that there was an increased incident of people relying on alcohol and other substances to get them through the pandemic. So we need to really tackle that as well in terms of the waiting lists that currently exist and those that we are likely to see into the future. It will certainly be a litmus test to see how seriously the government takes the issue of tackling the health crisis, both now with the current pandemic, but also into the future. Thank you very much.
That's absolutely excellent. Thank you. Interestingly, you could have been talking about the North for all that we have, that we have the NHS here. In terms of our health inequalities, it's not all that different. I mean, obviously, people don't have to pay, but actually there is still, so first of all, in terms of our life expectancy, the difference between a man, the life expectancy of a man in the least deprived area of the North and one in the most, in the least deprived and the most deprived is actually 7.5 years here. It's like almost double what it is in the South. And I keep on saying, if you were to say, Catholics or Protestants die 7.5 years before the other community, that people do murder about it, but because it's the poor, it's not so much of an issue. But also it is actually the case again, that precisely what you were saying that happens in the South, happens here, that the poorest people don't actually get to see doctors as quickly. I mean, and I can actually see it even when I'm looking for a GP. I can nearly always get a GP appointment. It's primary care here is completely free, so we never have to pay for to see any doctor. But actually, when you phone up and you sound like you know what you're talking about, and you maybe even the doctor knows you, because they might even be in your, you might actually know them from seeing them around town or, hanging out with them or whatever, you get, and even the receptionists treat you differently. Like I have literally been with friends, who've got working class accents, and they are treated completely differently when it comes to trying to access healthcare. And
absolutely. I mean, as I said, I'm from Finglas originally, which is a very working class area in Dublin. And certainly, like, my father's experience of accessing GP care was very, very different to my experience when I grew up and moved out. And, and that level of unfairness, that inequality drove me insane, because it is just a matter of socioeconomic group. That's all it is. And there's been so many studies, obviously, in relation to how poverty impacts people. But that issue of confidence as well, of being able to say, I need to see somebody and I have this issue, where a lot of people, and certainly people I would know from home, wouldn't have that confidence.
No.
It would be, there's a deference almost, and an inability to articulate it.
Yeah, and interestingly, up here, when it came to COVID, there was a headline in the newspapers that said, surprise, there are fewer people dying in deprived areas than in the better off areas. It took about 5 minutes for people like me to say, that's because there's not enough old people in the deprived areas to actually be killed off by this disease. So anyway, I'm going to hand over to Peadar now. But actually, you know, it does turn out that is literally what the problem was. In terms of under 65s, there's 2.5 times more people being hospitalized from deprived areas than from better off areas. But when it actually comes to deaths, you know, there was quite a few in the deprived areas as well. Okay, I'm going to hand over to Peadar because we want to finish with us speaking and actually get to the questions end of things. So again, I'll let Peadar introduce himself, but Peadar, a lot of you will know from his role in Doctors for Choice, but also because he's a child psychiatrist, quite often heard on the airwaves. Okay, Peadar, over to you. You got to unmute yourself, Peadar, and then introduce yourself.
Hi, my name is Peadar O'Grady. I'm a health activist and a child psychiatrist for a good number of years. How I'd like to come into the debate, actually, these are really good summaries, and I think crucially important summaries, both for the notion of a proper public health system, but also for dealing with COVID. And I want to deal quickly with both of them, but with a view to looking at what are the kind of solutions we should be looking at here. I know Adam touched on what solutions they're looking at in the States. But Colette's summary is super, and really what I want to do is say, if what Adam and Colette are saying is true, which I thoroughly believe it is, and a lot of scientific evidence to back them up, which they were quoting, then why persistently do we tend to ignore the Adams and Colettes who are telling us that these are the approaches you should use in public health policy to avoid discriminating against the poorer people in your society and to have an overall better system? Now, one of the things I think is very interesting about the study of inequality is inequality will imply there's a gradient in your access to what are wealth, services, and so on. But the interesting spirit level study showed that yes, and the poor will always do worse than the less poor and all the way up. But what the spirit level study showed was if you compare one society with another, actually, everyone does worse in a country where there is a steeper level of inequality. So while there's a certain nonsense to say we're all in it together, there's also a certain truth that it is not something that suits all of us to have a very unequal society. So that's the first thing that I would say. And in Colette's talk, she talks about inequality. Quite rightly, health inequality has to do with inequality, i.e. largely wealth inequality, which we have to have a way of dealing with. And I'm going to push the issue a little of the funding model, which I come back to Adam maybe in terms of the American approach, which is about having a single payer, but doesn't push as much the absolute necessity for dealing with your model of funding and where it comes from. Now, he talked a bit about it in terms of getting rid of co-pays and out of pocket. And to Colette, I would say as well, the challenge there for Sláintecare is that Sláintecare left those aspects, you know, reduced them, but left them there as if they weren't something you needed actually to get rid of rather than just kind of reduce. So firstly, with Adam's comment on America, the United States is the best example in the world of why for-profit healthcare should be avoided, right? It spends about twice what a lot of other equivalent OECD, you know, in developed industrialized countries spend, and doesn't even get their level of success. So they spend twice as much and don't get the same health outcomes. So it's a really inefficient model. And yet, most politicians, when you hear them talk about the private sector, they talk about it as if it improves efficiency. Well, the United States stands as the best example in the world. Double the cost and not even the same level of effectiveness. So there's a bit of science, and that's well established. People like, I think, Adam's colleagues, Steffi Woolhandler and another colleague wrote a paper about 20 years ago, very clearly establishing why this is. It's not because American healthcare workers are all lazy and smoking fags and drinking tea instead of doing their job. It is because a lot of that money is not spent on healthcare. Somewhere close to 50% of it, which interestingly would bring them to the amount of money everyone else is spending, is spent on excessive on profits, which don't have to be paid for in a not-for-profit system, about 10%, on administration about 35%, a lot of which is individual billing, which is a total waste of time. It's not a thing any health service has to do, and yet for-profit systems absolutely need billing. And they have to pay for it. That means the American people have to pay for it. And then you have executive salaries and legal fees and accountancy fees you don't have in a public system. And you have excessive profiteering like drug companies. Half of the profits that drug companies make are made in the United States. So again, United States citizens don't do well. We often think, oh, those Americans. But actually, US citizens do not do well out of this system, right? So that's the first thing I'd say. And the second thing I'd say is a not public system, a system that favors out-of-pocket payments, that favors your ability to pay rather than your level of need, are not good for the poor, but also not good for anyone in that society. So what I want to move on to ask then is, given that all this is true, why then do we persist with a system that resists that logic? Literally, in whose interest is it? So it's often thought, and often people pit, the poorer workers versus the better off workers. But in fact, the strongest dynamic pushing towards the for-profit model is for-profit corporations. And I think it has to be an important feature of our debate as to where they fit in. Either drug companies, health insurance companies, health management organizations, and the private hospitals themselves. Quickly on COVID, Ireland, Conor was mentioning earlier on that the American system was heavily privatized and the British system a more traditional public system. What's very interesting is both have done horrendously badly in COVID. The US doing badly has been very well covered. The UK doing badly is very poorly covered. And in fact, the UK death rates per head of population are higher than the US rates. So the British model, even though they went for a national health system, from the point of view of profit, restricting costs, Britain has one of the lowest costs, and a lot of which were acquired by a hyper efficiency, way more efficient than obviously than the US model, but cut to the bone. And in fact, what we are now seeing is cut beyond the bone, cut dangerously close. So when COVID came, one of the systems in the world which should have been best able to deal with it, a publicly funded national health system, in fact, was not, because of years of one, underfunding, but two, also these kind of market mechanisms forced on the NHS, which just disorganize it. But also the encouragement of the private sector, which we've seen with Boris Johnson. The two key elements of capacity in COVID are if people get sick, hospital beds and ICU beds, and a system for getting them there, not forgetting the GPs, but also the test and trace so that you can focus in and restrict transmission and so on. You've seen Boris Johnson sell that off to the private sector. He's got an NHS there waiting, has all of the systems in place in many ways. They're underfunded, but they're there. But he chooses to go the private model. In the in Ireland, in March, when everything broke out, what we did to respond to a surge capacity, given that we're very like Britain in terms of we've a very cut down model of public provision, and a little bit like America in that we've a very high level of private funding. We have the second highest level of private funding in Europe, but we've one of the lowest levels of capacity. So we've a very low level of hospital beds, 3 per 1,000 compared to an EU average of more than 4. And very low levels of ICU beds, which when people get sick, that's when they get their sickest, that's where they need to go. Somewhere around 5 and possibly even less. A lot of dispute about how many we have per 100,000 versus an EU average of about 11. So we've less than half the number of ICU beds we need. So how did we deal with that? We dealt with that by taking in the private sector under public control. Absolutely the right thing to do. Now, mind you, a largely non-acute sector, i.e. elective surgery, things that can be planned, because of course that's where the private sector goes, because you can reliably make profit in those areas. But now we're moving into October, and the health service is now expected to do 2 things that it didn't do in March. One, in March, it stopped doing the non-COVID work largely outside of emergencies, and it took in the private sector beds. Now it's given back the private sector beds, and it's expected to do both the COVID and the non-COVID work. So we have had a surge capacity, which we kind of faked in March. We just stopped doing everything else and took in the private sector. But now we are faced with actually that slimmed down capacity again, not an extra bed put in. I think they offered 17 ICU beds out of like 200. It's a pittance. It's just not realistic as to what may well be used. So to finish off, in terms of the implications of this, given all the evidence that public systems work best and you hurt the poor, and actually all of us suffer the higher the gradient is, why does this continue to happen? And it continues to happen because of a political commitment to profit within our healthcare system, either cutting the cost of the health service so taxes for the rich can be cut, or selling off bits of the health service for private profit. So there need to be several aspects to our campaign, not just universality, absolutely important in all its aspects. It must be for everybody, it must be for everything, and it must include all the costs of everything. Now, I think that's exactly where Sláinte Care fell down, because it allowed that notion that you can still allow the costs of a health service to fall on people in terms of out-of-pocket payments and so on. There's a lot of evidence that since the 2008 crash, that people prioritized health insurance over going to the GP or the dentist, which sounds a bit, it sounds a bit crazy, but it's not that crazy. People were thinking, if I get really sick, I need my health insurance to get seen quickly, but I'll skip meeting the primary care people that could make me not get sick. And you can see again how self-defeating that is. People will show up sicker than they needed to be and so on. So we need a universal comprehensive system, but we also need to be very clear about the funding, that we need, the more progressive the funding is, the more we're dealing with the 2 aspects, not just the aspect of access, but also the access of redistribution and dealing with that gradient. So progressive taxation reduces both. It improves access and it reduces health inequality. So we need to, I think, push that. And finally, I think what was wrong with Sláinte Care, a lot of what it advocated, I would be, yes, absolutely, but it conceded a lot. And I think one of the reasons it conceded is because the people pushing it had no power. There were a bunch of academics and a few left-wing TDs. They didn't have a street movement behind them. They didn't even have a largely organized, campaign within trade unions and so on that had any kind of leverage and pressure for implementation. And I think, to Adam's mention of 1945, Both the US was victorious and the UK was largely defeated after the Second World War. The UK was rubble. And it went for an NHS for two reasons. One, a huge swell of support for the Labour Party. So there was a big swing to the left, which you didn't see to the same extent in the States. And you had a Labour minister, health minister, who could come along and say to the doctors, here's some money, shut up, we're going to go and do this, and forced it through. So I think not alone do we need the good demands, we also need the campaign to push it through. You need a source of power. It's one thing being right, it's another thing being effective. So I leave it at that.
Thanks, Peadar. And the questions have been coming in hot and heavy. There's several questions, Adam, aimed at you, all of which are about very kind of similar stuff. I might try to kind of run them together because I think you might be able to address them all kind of sort of quite similar. So Christopher Carroll says that you talk about the role of the working class in developing health reform. Can universal healthcare be won without a social movement? Someone else, People for Profit student, says, could Adam comment on the role played by healthcare workers and organised labour more broadly within the movement for healthcare reform in the States? Kai El Baba Jones says, it's great that campaigners in the US are pushing for universal coverage, but asks Adam how much of that is as a result of how bad it's become, with skyrocketing costs, etc. And Miguel Orgel asks, can you give any thoughts on getting a system developing which is not blocked by big pharma? So they're all kind of around the same kind of issue. So you've got to unmute yourself and then solve the world's problems for us.
Okay, I'll do that in 2 minutes. So I think you're right. I think a lot of those questions are interconnected because a lot of them, pertain to the question of, how do you win and sort of what are the forces, sort of pushing this forward and what are the forces pushing it back. And, I think to some extent the answers are obvious in that, in 2020, the biggest barriers, and this was already said, to achieving a single payer system, or however it's termed, are giant corporate powers, right? And that was not as much the case 80 years ago. 80 years ago, I think the medical profession was probably one of the bigger sources of resistance, and the medical profession wasn't a corporate industry. It was sort of, I don't know the right sort of, how it would be classified in sort of Marxist terms, but it wasn't a big industry. It was what it was. It was sort of independent business people in large part, right? So that's changed. And now I think that physicians are not the biggest source of resistance in the United States or even in other countries. I think, as I mentioned, we actually have some polling that suggests that Medicare for All is actually quite popular with physicians. The current system, although, socialized systems are often, slurred as kind of being bureaucratic, it actually turns out, and Dr. O'Grady referred to this, the current U.S. system is enormously bureaucratic and administratively heavy. About a third of every healthcare dollar in the United States goes towards profits and administration, which is double the proportion of Canada, which is about $800 billion a year. So I think physicians are not happy in the current environment. So I think that what's new is that the commanding heights of the economy are now healthcare corporations, which is really new historically, right? I mean, these are the corporations that have, perhaps the most sway in our political economy, and these are international corporations. This isn't simply a United States phenomenon. So you have pharmaceutical companies which have, whose profits dwarfs all the other rest of the healthcare industry, and these are obviously international corporations, and they exert influence throughout the globe. You have health insurance companies that are quite powerful, and you also have for-profit hospital industry, which is quite powerful, and there's certainly international components for-profit care delivery. So the biggest resistance is giant corporations. I think in the current moment, and this sort of segues into the other question about healthcare workers, I think we're seeing rising support among healthcare workers. In the United States, the biggest nurses union is a union, a federation of unions called National Nurses United, which is, probably one of the biggest supporters for Medicare for All, and is well known for, making that at the center of their advocacy as an organization. So, and my organization, Physicians for a National Health Program, is, we have a lot of members and I'd say a fair amount of support. So I think that's really the primary bulwark against change at this point. Now I'm trying to remember what the other question was. Oh, I think there's a question about social movements writ large. What role do they play? And yes, this is not going to be won by technocracy. Now, I do think that having academics, having healthcare professionals as part of these campaigns is critical. For one thing, you need the healthcare professionals to be on your side, because they're going to be, the ones who are actually running the system, and you can't have a healthcare system that runs well if you've sort of alienated its actual workers, right? So that's critical. But second, they still have a lot of sway, I think, in every country in terms of public faith and interest in hearing their opinion. But even they are not going to win this, right? Because they're not powerful enough. So yes, you need labor, you need social movements. If you look at the vast majority of landmark health reforms in Europe and the United States and elsewhere have been pushed forward by progressive coalitions involving labor and often with left-wing parties that have actually pushed the laws forward. And that's the case in Canada to our north. Tommy Douglas, that some of you may have known, is sort of the father of the Canadian healthcare system, and he's held in very high regard in Canada. So the social movements are critical, but I do think there's a role for those of us who are sort of policy nerds as well, who can sort of speak to some of the arguments that are needed, that we need to make in order to actually convince a broader proportion of the population and policymakers as well. I think I covered at least some of those.
You covered an awful lot of them in a very short period of time, so that's really good. Thanks. There's actually loads more questions coming in, so I'm going to run a couple together for Colette as well, if that's okay. So Alva Smith and Marnie Holber in particular were asking about Sláinte care and whether you think it will actually make much of a difference to health inequalities. So Alva was suggesting that would it not replicate, it's up there, some of the inadequacies of Obamacare to meet real need. And then because it accepts private health insurance as like the people's choice, that it doesn't really see healthcare as a social right. And, could we not do better, I think is the real question. Could we not do better when it comes to healthcare, something better than Sláinte care?
Yeah, I mean, I think in terms of what Sláinte care does, and that we would certainly support, and that I would certainly support, is that it focuses more along the lines of, increasing GPs, along the lines of community care, and taking care out of acute centres and out of hospitals to free up acute centres for those who really need it. So to build up that capacity at community level. Whether or not it'll cure all the ills that I talked about, I don't think so. But I don't think any healthcare system in and of itself is going to do that. I think there are much broader societal systemic changes that are needed to address inequalities. I mean, I talked a little in terms of, it's dependent on poverty. We're looking at educational disadvantage. There's income disadvantage. There's housing problems. So there's a huge amount of connected problems. And if you were to focus on any one individual thing, so for example, we're talking about health today, and you look at that and you think, okay, if we completely sorted that, does that address everything? And no, it doesn't. If we completely sorted our housing system, our housing crisis, does that address all the inequalities? It doesn't. All of these things need to be done in tandem with each other, in kind of connection with each other, to properly address the societal inequalities that we have. And Peadar's absolutely right when he refers to that spirit level notion of, this kind of if there's a more unequal society, actually has difficulties for everybody, no matter where you are on the wealth spectrum. So it's really to try and close that gap. But in terms of, you know, absolutely, when we look at free healthcare as opposed to affordable healthcare, that is an issue. But certainly it's a step in the right direction compared to where we currently are, where we have unacceptable waiting lists, unacceptable occupancy rates, and very little in the way of primary care, with unacceptable rates in terms of waiting lists for home help.
Okay, I hope you don't mind. I'm going to come in a wee bit on this, because
Sure.
we're actually in the north here. We've got a couple of reorganization reports that have come in, and all of them recommend the same kind of thing that you're talking about, moving most of the care out into the community, having much better primary care services, you know, with physiotherapists and social workers and mental health nurses and all that as part of primary care, so that we become less dependent on the acute service. But it seems to me that to be sort of saying, you know, we'll do that under Sláinte care, keeping, you know, the notion that some people are going to be paying, like, why not go for the whole lot at once? That's just I mean, I'm serious, because...
No, I mean, I think it comes down to budgetary realities. And, you know, we have a high health budget as it currently stands. It comes down to the priorities of government and the political will behind it. But I mean, absolutely, you know, it is that thing of, if you could push all of the money into one particular area, where would you put it? But if you had to make choices, where should the choices be made? And when it comes to healthcare, my particular stance on it would be around the community and building up community capacity.
Okay, I'll let
Peadar's desperate to come in to fight with me.
Because I know what the answer is.
I am, because I think the answer again is historical. The NHS was introduced in 1947 with, you know, a more thoroughgoing set of recommendations, set of behaviours, free at the point of use, funded from taxation, universal, comprehensive, and so on. One of the things that was a little lacking in was democratic control. There wasn't enough in there to say that local communities would be able to be involved in the development of their health service, so that, you know, ensuring that it met their needs and so on. But in terms of getting rid of payment at the point of use, Sláinte care steps back. And to say that that is because the budgetary realities ignores the fact that an NHS is more efficient. It is, in other words, cheaper to do an NHS. Like, you imagine the United Kingdom in 1947, it was broke. I know it had an empire, but it was losing it. It was broke. And it went for this system not because suddenly they decided to get really flahulic and generous towards their masses. In two things were clear. One, this was the cheapest way of doing it. And two, the general public was not going to take no for an answer. Now, to be fair to Sláinte care, I think the reason that Sláinte care pulled back on things that are scientifically well established is not money, because that's also well scientifically established, is that you don't need to pull back on things to save money. Pulling back on things costs money in that way. So if we look at what they left intact, they left self-employed GPs, they left private nursing homes, they left private hospitals, and private insurance, and out-of-pocket payments. So there was no need to do that. They did that because it was politically difficult for them to push it through, to point out the core truth here is that profit-seeking costs money, and it reduces the standards of healthcare. And I don't think Sláinte care was prepared to do that. But, like, to be fair to them, they did not have, like, where does the power come from? Like, again, like I said as I finished, it's one thing to be right, it's another thing to be effective. And Sláinte care did not have the social movement around them to push things through.
I just want to add in relation to the NHS. I mean, it is the case that when the NHS was established, it was established on the basis very much of, you know, women being at home looking after kids, that there was no real need for any kind of community care, any kind of social care, because women were going to do all of that. They were going to look after the older people, or, you know, they were going to look after disabled people, they were going to do all of that. So no need for a more kind of community base. But actually, I do think it's important to say that here in the north, that one of the things that COVID has actually led to, I think it's happening in the south as well, actually, that one of the things that COVID has led to is that some of those community facilities are being set up now, not in any kind of, not in a planned way. They weren't planned to be set up this year, but because they're trying to get as many services as possible out of the hospitals and into places that are a bit safer than hospitals, because there's no COVID there. And we're actually seeing, you know, instead of them having to build big fancy buildings, they're moving into like warehouses and kind of getting the warehouses set up to be the kind of community health hubs that, you know, that we've been talking about for, I've been living in the north now like 35 years, and that's how long they've been talking about getting community care hubs. But I wanted to go back to other people's questions. This is a very interesting discussion about slow into care, but since we have Adam here, lots of people are asking questions of him. And one of the questions coming from Arnie Halber is, could you say something about what you describe as the medical industrial complex in the US? You've got to unmute yourself.
There we go. Yes, I mean, this is a term not that I, invented. It's a reflection of the reality of rising corporatization of healthcare, really probably beginning from the 1970s onward in the United States. And again, that's very international in its scope. So just to give a sense of the degree to which for-profit industries have sort of infiltrated the healthcare system. And I'm not just talking about private financing, I'm talking about private delivery. The hospices, which is, I think that's an international term, right? Hospices are majority of American hospices are for-profit corporate run. Nursing homes are increasingly run by for-profit companies. And probably a majority are now. Hemodialysis centers are run by two giant international companies, Fresenius and the other one is escaping me at the moment. And then I mentioned the for-profit hospital industry, and then, of course, the insurers. So, I mean, the term basically refers to this sort of, aggregation of all these powerful corporate entities. Maybe I could just say one word on because it preceded this, the user fee argument, because this is something that, just to segue into that real briefly, it's something that actually has become a major debate in the United States in terms of the kinds of the design of a Medicare for All system. And we have pushed very strongly for the Medicare for All bills to not have user fees. One of them in the Senate has small fees for prescription drugs, but nothing else. The House bill has none at all, which is how we think it should be. A lot of the arguments about the fact that eliminating user fees costs money, it really doesn't cost overall money in terms of overall healthcare spending. Yes, it requires more public financing as a proportion of healthcare spending. But the reality is that the overall cost of the healthcare system in and of itself is actually much better controlled with full public financing, as we've seen over the long term. And even in the short term, you don't see giant surges in the utilization of services once user fees are eliminated. You see modest increases or sometimes no increases at all as use of services shifts to people who are newly covered. So just my 2 cents on that issue.
Okay, thanks. So I think we're kind of, I notice people are kind of dropping off a bit, but there's a question that somebody's put that I'd like to put to all of you. And the point that they make is that so often as a healthcare worker, the best thing that you could do for your patient would be to change the world in which they live. And so they're asking, what role should or could healthcare workers have in tackling health inequalities? So just for all of you, it's kind of a way of getting all of you to do like maybe a little, say whatever it is that you've been thinking you wanted to say all along. while you're at it. So do you want to start, Adam? And
Sure. So, in all of my comments so far, I've only spoken about healthcare, not about health itself, which everyone else in the panel did speak to. But we know that the reality is that so much of health, the majority, is due to factors that have nothing to do with medical care. They have to do with, all of the things that make a society just or unjust. And we're talking, of course, about housing and education and access to food and overall economic inequality, which has been already noted that it is in and of itself is a fundamental driver of poor health and of health inequality. But the reason why I focus on healthcare and medical care is not actually because I think it's the most important thing when it comes to health. It's the area where I believe, as a healthcare worker, I have the most leverage and I have the most sway. And so that is, what my organization focuses on for the same reason. As an organization of physicians, we see our impact as an organization greatest when advocating for just healthcare. Now, I will say that the justice of the healthcare system and its universality has impacts that goes beyond simply delivering health itself. It actually can do harm if it is structured unjustly, as it is in the United States. So, for instance, if you do fund your healthcare system through user fees and through how we do it, through private premiums, you actually increase economic inequality because you're taking money on the basis of people's health needs rather than on the basis of their means. And what that means is your healthcare system then becomes a conduit and an amplifier of societal inequality. And that's actually having the downstream consequence of ruining, of worsening health. So, if someone goes bankrupt because they can't afford because of healthcare bills, well, that's going to hurt their health in a way that may even be greater than the absence or access to medical services, depending. I'm not downplaying the importance of medical care, but I'm making a case for both why it's important beyond the question of access, also why it's so important to me, because it's where I feel like I can have the leverage that I do and that we do as an organization. And it's an area that I also feel like is very accessible to the general public, and so is very on the forefront of their minds. So at the end of the day, it really truly matters to almost everyone in society. And there's very few other causes that you can always say that for. Even if it's true, it's not always visible. So I guess I'd close out by saying that as healthcare workers, just as citizens, there's many different ways that you can work towards making society better, as the question asked. And that answer is going to be different for everyone. So all I can say is, in my own case, I just think that oftentimes as a clinician or a worker within the healthcare system, you do have your voice is powerful when it comes to speaking on issues of care.
Thanks, Adam. Colette, do you want to? You have to unmute yourself.
Sorry. Yeah, I mean, I think picking up on Adam's piece around, engaging as a citizen and doing your piece. So in terms of engaging in campaigns that speak to you around healthcare, in terms of, advocating, in terms of using all of the knowledge and experience and expertise and the vast amounts of case studies that you have to advocate for certain positions in relation to policy. I understand from, speaking to some people that can be a very difficult thing to do in terms of, individual organizations, individual hospitals, in terms of speaking up and putting your head up, and that can be difficult. But just in terms of, engaging and supporting and being a human being to the patients that you have, because that is that can't be underestimated, that support that people give and that reliance that people have and that trust that people put in to healthcare workers. So to value that. But in terms of the bigger picture and the broader picture, it's really around that kind of engagement and how people can advocate and how people can come together to support something and to push policy in the right direction.
I was thanking you, Colette, and you couldn't hear me. Sorry. That was excellent, thanks. And Peadar, you need to unmute yourself, and yeah.
I guess just coming back very quickly, because I think the capacity issue is a huge issue, and I think I don't want to appear in any way disagree with Colette about community supports and community service. Absolutely necessary, but it's a case of as well as rather than instead of. And I think the notion that the capacity of the acute sector is fine, but we need to fund, and that in some way this cross-party support, it's as if the right-wing parties agree with this, and they don't. In the period since 2008, since the crash, it was the non-acute side and the community sector that was most cut back. So in the period when all of these shoes were under the table with the right wing pretending to agree with the very earnest people pushing stone chicken, they were meanwhile actually attacking community-based health services particularly, and they put the acute services back first. But this is not surprising, because it is the acute services when they're missing, they're just the most noticeable. It doesn't mean they're the most important. And in many ways, from a preventive point of view, it's absolutely correct. We need decent community and primary care services. They are in disarray. They're largely privately kind of run in terms of how GPs operate and how nursing homes operate. And they are very, very poorly funded in terms of the kind of social services. In mental health, we're always, we talk even very mainstream, we talk about psychosocial supports for people as alternatives to folks in PCT and strength, and all the more coercive measures. But that means having those kind of resources. We're in a housing crisis. One of the key things in mental health supports is ensuring somebody has some sort of security when it comes to food, when it comes to shelter, and so on. If you're fearful of very basic things, how is anyone? I call it psychotherapy for the drowning. It's like, you'll be okay. Why don't you pull me out of the water? Well, because we don't have the resources to pull you. That's very hard for mental health workers. So finally, what should we do? We should get involved. We should get involved and see it as not, opposed to the interests of our patients, what have you. I think particularly the trade unions, and I'm speaking to everyone out there, not just health workers or trade unions, but anyone who's in the workplace, who's involved in a trade union, or who's involved in any kind of collective action, to join us and get involved. I think what Colette and Adam are saying, and what I am saying is, yes, if you're going to pick something, health is one of those things. We certainly need health workers and the people who use services to join together, because without that kind of collective effort, we just won't have the power. I think everything we're saying, I think some great things have been said, some very true things have been said this evening, but we're powerless without the support, without a campaign pushing these things forward.
Thanks, Peadar. Your sound is off, so it was really, really bad. I think that's been a really, really good discussion, and I think that one of the things that first of all, just to say that anybody who's able or willing to sign up to the campaign, you can do it. There's a sign-up link in the comments section here. The idea of the campaign for an All-Ireland NHS isn't just to replicate what's in the NHS. We don't think that's good enough. We're really clear that we want an NHS that includes a national social care service, so that social care is free at the point of delivery, in the same way as hospital care or your primary care is. And we think that we need to be bold, and we need to go fully to try to get that kind of a service across the entire island. It seems like it's a good opportunity. COVID has shown us that actually that the island we live on is too small to have two separate systems. It has just been ridiculous there for a while. Like, I live right on the border, I could walk, you know, from here where I live in the north of Ireland to the Republic of Ireland in 20 minutes, doing it fairly slowly. And yet, you know, we have two separate healthcare systems, and we have two separate non-social care systems. And as I say, COVID showed that it makes no sense whatsoever to be, you know, giving out, we're getting two lots of healthcare messages and public health messages. Although I have to say that we in Derry just took whatever the Republic was saying and did it. We weren't going to listen to them ones up here in Stormont, and we knew which side our bread was buttered on. But it's actually important to say that we won't, I don't think, we won't even start to tackle the worst of the health inequalities until we get a much more joined up healthcare system. And so the campaign for All Ireland NHS isn't just a campaign for, like I say, a 32 county version of what we've got in the north. It's actually trying to re-envision a health service that would actually allow us to have something that, you know, well, I guess would mean that we could kind of ameliorate some of the inequalities that are caused by the gap between the rich and the poor. So I think, because I can see that people are leaving, that we should wind up soon, but I want to give both Colette and Adam a chance if they want to come back and say anything additionally. Peadar went off to, I think, to try to sort out his sound. I'm not having you back unless you sorted it out, because you couldn't hear half of what you were saying. I'm only teasing. If you think you've sorted it out, you can have it. You can come back. So do either of you two have anything that you want to say? Just unmute yourselves if you want to, if you have a last thing you want to say.
I think I've said a whole lot, so I'll just say thank you for having me, and really enjoyed the discussion.
Well, thank you so much for coming, Adam, because it's great. One of the great things about all this lockdown stuff is that now we can have people, you know, coming from the Boston area and just as easily as coming from Dublin. So thanks. Colette?
Yeah, just to say thank you very much. It's been really interesting. It's been a really interesting discussion and debate at times, and it's been fascinating to hear the other speakers as well, and great to contribute. You know, it is something that we really do need to get a real handle on in terms of healthcare and in terms of just how badly we're dealing with it, you know, even pre-pandemic. But yeah, I mean, I think in terms of movements, I think they're if we could get a push in the way we have had similar kind of movements established, it would be, you know, really beneficial, I think, to get something that is better. So thank you.
Okay, so thanks everybody, and I'm not actually sure when the next public meeting was, but if you've left your name in the sign up in the comments, then you'll get an email about it anyway. We have a public meeting like this, you know, that we kind of spread the word about every 3 weeks. So we will be having one again fairly soon, and hope to see you all then. Okay, bye.